Myself, Dr. JIBRAN Ahmad presents to you Simply Pathology, and today we are back with a very important session. As you already know that today we are going to start the biopsy series and we are going to start with the liver biopsy part 1. So yes, liver biopsy is a very important topic for your exams and it is going to serve two very important purposes. Number one, in your viva they might keep a liver biopsy needle and therefore all the details and particulars regarding liver biopsy will be asked to you. Secondly, in the exam, in the final exam, a long answer question comes on the biopsy interpretation of the liver. So we are going to discuss both these sessions, okay? So in today's topic of discussion, we are going to discuss the part 1 of liver biopsy, wherein we are going to discuss the basic introduction, the types of biopsies, the indications and the contraindications, what are the prerequisites, how the procedure is carried out, what are the common complications faced, what is the adequacy, handling and processing of liver biopsy, and the choice of stains. So all these will be discussed in details today, okay? So please pay a lot of attention, very important from your exam point of view. In the part 2 or in the next session, we are mainly going to discuss the basic interpretation of liver biopsy in general, okay? So without wasting any time, let us begin today's topic of discussion, that is liver biopsy part 1. So the basic introduction, if you see, so try to understand that liver biopsy is a procedure in which a small piece of liver tissue is removed and examined microscopically to determine the cause and severity of the liver disease. So you have to understand one important thing, that over here we are taking a small piece of biopsy, okay, and we are examining it microscopically so as to determine what is the cause of the disease or what is the severity of the disease. So you have to note few things, that liver biopsy in general is not required for diagnosis of a typical case of acute hepatitis, not all cases, but a typical case of acute hepatitis, and also it is not required for diagnosing biliary obstruction. Why? Because for biliary obstruction right now modern imaging techniques are available which are far more useful as compared to the liver biopsy. So what are the indications of carrying out a liver biopsy? Number one, acute hepatitis of unknown cause, so where the cause of an acute hepatitis is not apparent, okay? So basically in that case we might carry out a liver biopsy, okay? What is the typical? For example, after acute viral hepatitis, when you know they are serology positive, then you know the cause, so you don't have to carry out a biopsy. But in acute hepatitis of unknown cause, you have to carry out biopsy. So liver biopsy is usually not required for a typical case of acute viral hepatitis, as already stated above. Then second indication is in chronic liver disease, so as to define the cause of the chronic liver disease, okay? Second, grading of the inflammatory activity as well as the staging of chronic hepatitis, both hepatitis B and C, as well as to monitor the response to therapy, okay? So for chronic liver disease, these are the indications. Then liver biopsy is also used, okay, for investigating a persistently abnormal and unexplained LFT. So it is not like that for example you have an abnormal LFT, so the doctor is going to perform liver biopsy. No, only when your liver function tests are persistently abnormal that the doctor is going to advise for the liver biopsy. Investigation as a part of the full spectrum of checkup, as a part of investigation of pyrexia of unknown origin, they can do this. For diagnosis of granulomatous disease also, example like tuberculosis, you can do the liver biopsy. Then it is also done for the diagnosis and grading of alcoholic liver disease, diagnosis of metabolic liver disorders like hemochromatosis and Wilson's disease, as well as quantification of accumulated iron and copper respectively. So as we know, in hemochromatosis there is iron accumulation, in Wilson's disease there is copper accumulation. So for the diagnosis of these metabolic liver disorders also liver biopsy can be performed. It is also done for the detection of intrahepatic cholestasis, wherein it is useful for accurate staging in advanced cases of primary biliary cirrhosis and primary sclerosing cholangitis. Also, they are used for the diagnosis of focal hepatic lesions, example liver tumors, both primary or metastatic. Then they are also done for the histologic monitoring following liver transplantation. It is very important, and it also plays an important role whenever there is a graft versus host disease in recipients of hematopoietic stem cell transplant, okay? So these are the 11 very important indications of performing a liver biopsy. So what are the contraindications? The first important thing, if the patient has given consent but the patient is highly uncooperative. So if the patient is moving a lot while you are performing the procedure, there is a high chance of liver laceration as well as bleeding. Okay, so uncooperative patient, for safety reasons, you have to, stop doing the procedure. Secondly, if the patient has refused to undergo the procedure after having an informed, or after having a detailed explanation of the procedure and the risk. So if the patient is refusing after an informed, explanation of the procedure has been made, so absolutely it is a contraindication. Thirdly, when there is a suspected hemangioma or a highly vascular tumor. So if there is a, if you are suspecting a hemangioma or a highly vascular tumor, so there's a high chance and risk of bleeding and the patient might bleed out to death. Okay, so that is why when you are suspecting a vascular tumor, you should not carry out a liver biopsy. Okay. Fourthly, bleeding tendency or an abnormal coagulation profile. Now you have seen that over here I have put an R. R means relative. It is a relative contraindication. So when the prothrombin time is more than 3 to 5 seconds above control, or the platelet count is less than 50,000 per microliter, or the bleeding time is more than equal to 10 minutes. In such cases, it is relatively contraindicated. So you might be able to carry out the procedure, okay, after administration of vitamin K or giving the platelet concentrates to the patient, or after correcting these abnormalities, you might perform. So these are relative contraindication. Then another absolute contraindication is hydrated cyst of the liver. Why? Because once you puncture and if there is a hydrated cyst, the cyst content might leak out into the peritoneum, inciting a anaphylactic reaction. So then increased risk of anaphylactic reaction. So again, this is an absolute contraindication. Another relative contraindication is a tense ascites, because when the entire abdomen is filled with fluid, so it will be very difficult to obtain a liver tissue, because and there is an increased risk of bleeding. So after you tap the ascitic fluid, okay, after that it might be, the biopsy procedure might be attempted. Okay, so in cases of tense ascites, again, it's a relative contraindication to carry out the liver biopsy. Then if there is any infections in the right pleural cavity or below the right diaphragm, again a relative contraindication. You can you can give broad spectrum antibiotics, and then when the infections come down, you can carry out. So again, it is a relative contraindication. Again, in conditions of amyloidosis, usually they are associated with an increased risk of bleeding. So again, it's a contraindication. Ninth, when there is an unavailability of blood transfusion and surgical support. So if the support is not there, and if you are not, if the emergency support is not available, then it is better not to carry out the procedure. In conditions of extrahepatic biliary obstruction, wherein you are having a dilated bile ducts, so there is a risk of puncturing them and then leakage of bile leading to biliary peritonitis. So again, in conditions of extrahepatic biliary obstruction, it is a contraindication, absolute contraindication for carrying out a liver biopsy. So these are the indications and the contraindications of liver biopsy. Believe me, this question will be asked to you in your viva. Okay, if the particular true cut needle or the Wim-Silverman's needle, if it is present in your instrument tray, this will be asked. What are the indications? What are the contraindications? Okay, so you have to explain each one of them in detail. Now we are going to see what are the different types of liver biopsies which are carried out. So there are many different types, okay, but the most common variety is the percutaneous liver biopsy. Okay, so the percutaneous liver biopsy, basically that means can be done in three basic ways. Okay, so in the percutaneous variety, it can either be a blind procedure, which is also most commonly carried out. So blind procedure is basically done for diffuse liver disease. Blind means when you are carrying out the procedure, without any CT, ultrasonography or MRI guidance. So you are doing it blindly. So that is basically blind, percutaneous liver biopsy. So the biopsy over here is carried out without any real-time imaging guidance. So first you have to percuss the liver borders and be sure where the liver is, and then the biopsy needle is inserted either through the intercostal space, means in between the intercostal space if the liver is enlarged, or for example via the subcostal route. You have to do it below the ribs. Okay, if the liver is not that much enlarged, then subcostal route has to be taken. So usually it is done between the 9th and 10th intercostal space in the right mid axillary line. Okay, usually this is the site of carrying out the liver biopsy. Okay, this is the blind percutaneous liver biopsy. Then the second important is the guided. Now guided ones is mainly used or mainly suggested when the lesion is not diffuse, rather it is focal. So you don't know, you blind, you are performing, but under the guidance you know exactly the point where the lesion is, where the focal lesion is, so you can actually do a precision guided biopsy. So usually over here we are doing it under CT, USG or MRI guidance, though under real-time imaging we are carrying out. And there is another way, where you can carry out the percutaneous liver biopsy, that is plugged. As the term suggests, what happens that after you take the biopsy, okay, the outer sheath of the needle is left in place and the obturator which is holding the liver biopsy is removed. Now this outer sheath which is already left in place in the place of procedure, through that a cannula is introduced through the outer sheath and a gel or foam is injected to seal or to plug the track in the liver. Okay, so this is basically done to reduce any risk of bleeding in individuals who are having impaired coagulation. I hope this point is crystal clear to everyone. So percutaneous liver biopsy is the most common method of taking the liver biopsy, and it can be blind, guided or plugged. Okay. Now liver biopsy needles, very very important in your practical vivas. Okay, any of such needles can be placed and you might be asked a lot of questions on this. So look at the liver biopsy needle. There are three important types of liver biopsy needle. One is your cutting needle, we have suction needles, and we have spring loaded cutting needles. So among the cutting needles, very commonly right now in our institutes we are mainly using a use and throw true cut needle, right? So we use a true cut needle. And the second important needle is the Wim Silverman's needle, Wim Silverman needle. Now, these cutting needles, if you see, they require longer time for biopsy and they remain in the liver for longer time. So the risk of bleeding is more in case we use cutting needles. Whereas in case of suction needles, there are three main types. One is your manganese needles, Latkin's needles and Jamshidi needles. Don't worry, I am going to show each of these needles. Okay. So these suction needles, they often cause fragmentation of cirrhotic liver and they are preferred mainly in case of focal lesions. We are using suction needles. Okay, so always remember when you're carrying out this liver biopsy procedure, the patients with encephalopathy, hepatic failure, or who are having severe jaundice or severe heart failure and advanced stage, they are at an increased risk of complications following liver biopsy. Okay, remember they are at an increased risk of complications following liver biopsy. Okay, so let me show you. Okay, so this is how you are carrying out the most common percutaneous liver biopsy, wherein a piece of tissue of the liver is basically, it is a small slender core of tissue is removed with the biopsy needle. It can either be blind, it can either be, real-time imaging guided, or it can be plugged variety. Okay, so this is the core of tissue that you have removed. So this is basically the percutaneous . This is the blind, okay, where you are not doing under any guidance, usually done in the diffuse liver disease. Over here you can see the USG probe is over here, right? And through this we are basically inserting a true cut needle is basically inserted over here. So this is basically USG or real time imaging guided, okay, USG guided percutaneous liver biopsy, okay, percutaneous liver biopsy, as we can appreciate over here. Okay, now I will just show you the needles that we are speaking about. So I already told you there is a cutting needle and there is an aspiration needle, okay, or suction needle. So this is a very common Wim Silverman's needle, very very commonly kept, okay, as a instrument in your practical exams. Okay, very very common instrument, both at the level of MBBS and in the PG level they are keeping this. Okay, so over here if you see that there are three important parts. So one is the cannula, then we have the stylet, and then we have a forked or split or bifid needle. Now if you look at this needle over here, it is longer, okay, as compared to this particular cannula, and it is protruding out of the cannula. It has very sharp cutting edge, so the cutting edge is very very sharp, and it has a groove, it has a longitudinal groove. So what happens that this groove retains the tissue when the needle, this is basically the needle, when the needle and the cannula, when they are withdrawn, okay, then the piece of tissue is retained over here. Okay, this is the main job. This is the Wim Silverman's needle. So I hope you have understood the different parts and you are able to explain about the Wim Silver needle in taking the liver biopsy. The second kind of cutting needle is the true cut needle that we very commonly use. Now there are different companies and different varieties. Okay, of taking this liver biopsy. Okay, so every institute have their own. So there are many different private companies, or there are many commercial varieties of this. So we just call it as a true cut needle. And then you have the manganese needles, wherein you see this is a very important feature of the manganese needle, wherein you have a trocar for setting the length, okay, of the cannula that will go inside. Okay, so you have this very important manganese needle. Okay, now these are the different biopsy needles. So as I told you, there are two types. One is the cutting type, one is the aspiration type. So cutting type, there's a true cut biopsy, as I already explained. Wim-Silverman's needle with these three parts. And there's an aspiration type, which is Jamshid's needle can be used, Latkin's needle can be used, and we have manganese needle as well. So these are the different types of liver biopsy needles which is commonly used, and most commonly in the exam they are keeping the Wim-Silverman's needle. So you should know everything about that. Now remember one thing, that liver biopsy procedure is not that much important for a pathologist, because the pathologist seldom is performing the procedure. It is mainly the clinician or the hepatologist or the gastroenterologist, okay, who have done the DM in the field. They are the one, or the specialists who are performing these procedures usually, okay, or the surgeons, they are performing the procedure usually. Okay, so that is why a lot of details about the procedure is not required. It is mainly important for, as a pathologist point of view, what is important is that you have to know the biopsy interpretation. So the part 2 becomes very important. But these details that I am discussing in today's topic of discussion is also important for answering many questions, and they will also form the part of the answer when the biopsy interpretation of the liver comes, okay, in the exam. Now the second important way, so this is the first and the most common way that we have discussed, okay, for taking the biopsy, that is the percutaneous liver biopsy, okay, the most common method. The second important method over here is the transjugular or transvenous liver biopsy. So over here, what is happening? A small catheter is introduced via the jugular vein of the neck and radiologically guided via the right atrium and IVC, inferior vena cava, into the hepatic vein. Then biopsy needle is then inserted through the particular catheter that was introduced prior, and it is advanced into the liver, and then the biopsy is taken. Now the method is suitable in conditions where there is relative contraindications, like in conditions of massive ascites or in conditions of severe coagulation disorders. We can go for the transvenous or transjugular route. Now remember one point, I will show you that route. One important point about that is this, that because you are entering the right atrium, okay, and the IVC also, so there is a risk of cardiac arrhythmia. So you have to do close cardiac monitoring while carrying out the procedure. So this is the transvenous or the transjugular approach. As you can see, they are entering via the jugular vein into the right atrium, inferior vena cava, and then they are entering the liver. And then through this particular catheter introduced, we are introducing a biopsy needle, and then a biopsy is classically taken. Now because the right atrium is involved, the heart is involved, and arrhythmias can happen anytime. So close cardiac monitoring is very important. So this is the transjugular. And what is the major indication of transjugular approach? In conditions of massive ascites or severe coagulation disorders, which are relative contraindications for carrying out the percutaneous liver biopsy. Okay. Now the next important way, let me show you. Okay, what is this? This is the open biopsy. This is the laparoscopic biopsy, which is another method. I will discuss it once. Just wait. Okay. So other methods are, one is the transgastric or endoscopic ultrasound USG guided. So it is useful in the diagnosis of hepatic masses and for certain lesions that are inaccessible by the percutaneous route. So you can also do an endoscopic USG guided transgastric liver biopsy. Then the fourth important type of taking biopsy is when you open. Okay, you can take an open biopsy. Either you can do an open surgery completely, you can take a wedge biopsy or resection specimen, or you can do a laparoscopic procedure. So surgically this is possible, or during transplantation you can also take the biopsy during transplant, okay, as in conditions of explants of native liver of the recipient. So these are the four important ways, and this is a laparoscopic biopsy that we are taking over here. Okay, the laparoscopic biopsy. Okay. So with this, we have completed the different types of biopsies that we are performing, starting with the percutaneous variety, wherein we were having aspiration needle as well as cutting needle, and the percutaneous variety can be blind, guided, or plugged. Okay, and then the different types of needles we have also discussed. Okay, and the relative advantage and disadvantage. Then the transjugular approach is there. Then the transgastric approach we had seen. Then the surgical approach, the open biopsy, where it can be open or it can be it can either be open or laparoscopic or during transplantation. Okay. So what are the prerequisites before you carry out a liver biopsy procedure? So the prerequisites being a prior imaging is necessary to rule out any abnormality, to define the liver borders and to see the relative positions of other organs. A routine hemogram to see the platelet count again is very important. A coagulation profile so as to understand what is the PT, prothrombin time. An informed consent of the patient. Informed consent means many a times the examiner is asking you this. What do you mean by informed consent? Then you are saying that you have to sign some papers. No, that is not informed. Informed consent is prior to taking any signature, you have to explain the entire procedure to the patient. Okay, what are the risks, what are the benefits, and what are the likely complications which will take place, which can take place. So all these things comes under informed consent. Then the blood grouping and the cross matching has to be done in case there is a severe bleeding. So blood should be ready for transfusion. Okay. So what is the method? Now we are not going into the details of the method and how it is carried out. Only superficially we will understand, because again this is not carried out by the pathologist. So the patient is lying in the supine position. You have to select the site, give local anesthesia, give a small incision, insert the biopsy needle. It is passed into the liver. The patient is asked to hold the breath in expiration. Okay. After the needle is removed, the patient lies supine or on the right side, and the patient is monitored especially in the first 4 to 6 hours, because majority of the complications takes place in that time. So you have to monitor the patient post procedure. It's not that the patient will go home. Okay. So what are the complications that we face? So pain is one of the important complications. You have pain. Most commonly, the most common complication if you see is hemorrhage, especially intraperitoneal hemorrhage. Increased risk in patients with cirrhosis and malignancy, the risk of hemorrhage, and it is not to be biopsied on OPD basis. Remember, liver biopsy should not be taken. Although many people are taking and doing the procedure on OPD basis, but it should not be done on OPD basis. Okay. Then hemorrhagic shock, it is the most life-threatening complication. Okay, the same hemorrhage can give rise to shock if the bleeding is not controlled. Then infections, any surgical procedure has chances of infection, so should be done under the cover of broad spectrum antibiotics. If you puncture the bile ducts or the gallbladder, it might lead to the leakage of bile, leading to biliary peritonitis, or you might puncture the lungs, okay, or leading either to pneumothorax or hemothorax. Then in case of HCC, you can spread the infection, causing needle tract seeding of HCC. Death is rare, okay, 0.1% mortality risk is there. And during the procedure, you might puncture other organs, okay, other visceral organs might be punctured while carrying out the procedure. Now the next important heading is the adequacy. Now this is what is a favorite question of examiner. So wherever any controversy lies, okay, the examiners are quite excited about that thing, okay, and they want to know your opinion. So it is very controversial. So it depends, the adequacy of the procedure will depend on the indication of the liver biopsy. Now usually a small biopsy can be adequate for diagnosis of a malignant tumor or any diffuse process in the liver. So you can take a very small biopsy, that will be significant enough. And a large biopsy is mainly required for grading of chronic liver disease where there is an unequal involvement of the portal tract. So the portal tracts are not involved diffusely. At some places they are all right, at some places they are not all right. So over there a larger biopsy tissue piece, that has to be taken. Now Ackerman, it states this minimum requirement, okay, the adequacy or the minimum requirement. This is the minimum, not standard. So Ackerman is stating that the biopsy length minimum should be 1.5 centimeters or 15 mm. Okay, and the core should comprise minimum of 11 complete portal tracts in the biopsy. Standard in different places have different standards. So I have taken a range. So the standard size, the recommended size for the core is 2 to 2.5 centimeter with at least 10 to 12 complete portal tracts. So this is the basic adequacy, okay, of taking the liver biopsy. Very, very important from an exam point of view. Okay. Now handling and processing of liver biopsy. How do you handle a liver biopsy and how do you process? So gross examination may sometimes provide clue to the diagnosis. So normal liver tissue, usually they are brown in color. Whereas if it is red, grossly means when you look through the naked eye, if it is red, it is suggestive of congestion. If it is green, it is suggestive of cholestasis. If it is yellow, suggestive of fatty change. If it is dark brown or blackish, suggestive of hemochromatosis or even Dubin-Johnson syndrome. White suggest fibrosis or any stromal rich tumor. Now remember, for fixation, the biopsy should be fixed in 10% formalin, very important, for a minimum of 2 to 4 hours. Now, squeezing artifact due to the use of forceps to pick up the biopsy must be avoided. Fresh and unfixed specimens are necessary for frozen sections, which is carried out for diagnosis of metabolic liver disease like hemochromatosis or Wilson's disease, or for demonstration of fatty change. Okay, also it might be used for microbiological studies. Electron microscopy, for electron microscopical studies, like in case of alpha 1 antitrypsin deficiency, 1 millimeter cube of tissue should be fixed in 2.5% glutarialdehyde. Now, formalin. Now, usually in majority of the cases, we are doing a formalin fixed tissue, and this formalin fixed tissues should be processed in automated tissue processor, although it can also be processed in the manual setup as well. Now, rapid processing within 2 hours is usually used in urgent situations, especially post-transplantation, to gauge any kind of rejection or acute rejection. That is why rapid processing is needed, post-transplantation. If you look at the normal liver core, as I told you, they are brown in color. This is the normal liver core biopsy. Okay, this is how it looks like. If you see under the microscope over here, this is the histopathology HP image or the histology image. So over here, if you see this part, this is the normal liver or plate. But if you see over here, this part is basically involved by hepatocellular carcinoma. How you can say? Look at the very thick hepatic plates like trabecula, more than 3 cell thick, 2 to 3 cell thick. Okay, this is actually involved by hepatocellular carcinoma. This is how I just wanted to show you how a core biopsy looks like under the microscope. Okay. Now, very important for assessment of rejection. Okay, remember one thing, that post transplantation that we are saying rapid processing is required in urgent situations, especially in post transplantation assessment of rejection, so as to start treatment as soon as possible. It is advisable, remember, to cut as many sections as required in one go, since every time the paraffin block is trimmed, precious tissue may be lost. Okay, precious tissue may be lost. At least 6 slides should be prepared from each block with 3 to 4 strips on each slide. So at least 6 slides should be prepared from each block with 3 to 4 tissue strips on each slide. So if this is a particular tissue slide, okay, so every slide should have at least 3 to 4 tissue strips. Okay, and you should have at least 6 such slides. Okay, and you should, in the first go only, you should cut many slides, so that because the tissue can be lost, because every time you are taking a particular slide and you are taking sections from the block, you are trimming the tissue. So if you are taking all the sections in one go, so the amount of tissue lost in trimming is less. Okay, approximately there is a range 3 to 6 micron or 5 to 8 micron thick sections should be routinely stained with HNE, okay, reticulin, as well as PAS-D and trichome. So this is a routine staining. At least these two is to very important and routinely done whenever you're taking a liver biopsy. HNE and one reticulin stain is very important. Okay, so this is about how you have to handle. Again, a lot of questions they come from here. Okay, so handling and processing of the liver biopsy. Then the special stains and what are the uses. So very important, along with an HNE, standard HNE which is done, very important is the use of reticulin stain. Because the reticulin stain, it outlines the framework of the liver as well as the lobular architecture. It is useful to identify any alteration in the structural framework. Example, loss of reticulin framework in hepatocellular carcinoma or fibrosis pattern, or alteration in the hepatic architecture in massive hepatocellular necrosis. There is a collapse of the architecture, or the entire reticulin network is collapsing. Okay, so in massive necrosis, I will show you with the help of an example. So this image, as you can appreciate over here, the reticulin stain showed in black color. This is the portal vein, this is the central vein, this is the zone 1, 2, 3. Okay, this is the centrilobular area. Okay, and this is the portal area. Okay, so the reticulin stain over here is showing the normal liver parenchyma with portal tract in the top left of the image, as we can see, and the central vein in the bottom right. Zones 1 to 3 are labeled. So this is how the normal architecture of the liver can be appreciated. Now we will see a case where there was a massive necrosis, and usually necrosis affects the zone number 3. Over here, if you see around the centrilobular region near the central vein, this area, You compare this area where the reticular network has completely collapsed. Compare with this normal area. Okay, compare with this. So this is why the reticular framework is very important. Now, such collapse of the framework will not be appreciated very well in the H&E stain. That is where the role of reticulin stain comes in. Okay, so over here you can see the reticulin collapse. So this is highlighting the reticulin pattern in acute hepatic necrosis. The hepatocyte cords are focally expanded over here. Okay, and band-like area of reticulin collapse. This is the area of reticulin collapse. As you can see, this is the area of reticulin collapse. What has happened that whatever hepatocytes were there, they have undergone necrosis. Okay, so because of that reason, the reticulin network has completely collapsed. Okay, and that is being highlighted very nicely over here. Okay. The next important stain that we use is the Mason's trichome, which is basically identifying fibrosis and identifies the collagen. Simple pass is basically highlighting the glycogen and basement membrane, identifies them, and it is very sensitive but very non-specific. Pass with diastasis pre-treatment or resistance is basically a pass with diastasis pre-treatment is important for detection of alpha-1 antitrypsin globules and ceroid pigment. Rhodanine stain is useful for detection of copper, for example, in Wilson's disease. Pearls of Prussian blue helps in the detection. Okay, iron or hemosiderin stain helps in detection of for example, in case of iron overload conditions, okay, as well as in conditions of hemochromatosis. Congo red is helpful in detection of amyloid. Oil red O helps in detection of lipid, and remember it is only done in fresh unfixed tissue for microvascular steatosis of a fat detection, lipid detection. Why in fresh unfixed tissue? I have already spoken about that in details in the tissue processing part, so I am not discussing that part again. Mason's Fontana for detection of melanin. GMSA can be used for detection of LD bodies. Okay, so this is about the special stains and the choice of stains that you are using in case of liver biopsy, special stains. Okay, and lastly, we are going to discuss the immunohistochemistry. Now, before we discuss the IHC, let me show you. So over here, you can see iron stain, okay, showing marked iron deposition in mixed distribution in the hepatocytes and Kupffer cells. Over here, you can see the pass stain after diastase pre-treatment or digestion, showing the globules, okay, consistent with alpha-1 antitrypsin, eosinophilic globule. This is the Congo red stain, showing orange staining vascular amyloid deposit. This is the amyloid deposition in the liver biopsy, okay, around the vessels, okay. Now, IHC again is very important for detection of antigens of infectious agents like HBsAg antigen, HBC antigen, HCV, HDV, cytomegalovirus, okay, herpes simplex virus, HIV, adenovirus. Now, for example, HBsAg, it is basically showing cytoplasmic positivity. HBC is showing both nuclear as well as cytoplasmic, positivity. Now, cytokeratins, that is positive mainly in the hepatocytes, are CK8 and 18, whereas in bile duct epithelium is showing, positivity for 8, 18, but specifically they are showing positivity for 7 and 19. So these are specific for the bile duct epithelium. For visualization of bile duct, this is very important. Okay, cytokeratins. Okay, so with the and one important point I would just like to highlight before I complete this particular session, that in a normal liver, remember the capsular. So this is the normal liver. Okay, remember this is the normal liver. Okay, remember this is the capsule area, right? So remember that in normal liver, the capsular fibrous tissue dips, okay, as trabeculae into the subcapsular parenchyma. So over here there is some fibrosis, right? And they're dipping like this, okay? They are dipping like this, deeper down like this. Okay, so over here there is some natural amount of fibrosis that is already there in the subcapsular area. Let me just show you once again in a clear way so that you understand well. Okay. So this subcapsular, fibrous tissue is dipping down like this, okay, like a trabecule, it is going down like this. Now suppose this area of subcapsular area, they show fibrosis plus they show inflammation, okay, inflammation far in excess, much more than what you see in the underlying parenchyma. Okay, remember this point. So in normal liver, the capsular fibrous tissue dips as trabeculae into the subcapsular parenchyma for a variable distance of approximately 5 mm. Further, the subcapsular tissue shows inflammation and collapse far in excess of what is found in the underlying parenchyma. So for example, there is some pathology over here, okay, maybe there is a mild pathology, but over here in this subcapsular area, this pathology is much exaggerated. So the fibrosis and inflammation is far in excess what is depicted in the underlying tissue. So whenever you take a liver biopsy, you should always be done, you should always do it from a deeper liver. You should always perform a deeper, you should always take tissue from a deeper region and not from superficial area. So if you take, from a superficial area, you might falsely report it as, a case of acute hepatitis, or you might, a case of a hepatitis, or you might diagnose it as a cirrhosis, because normally fibrosis and some inflammation is present in the subcapsular area. So always you should take biopsy from the deeper liver tissue. So deep liver biopsy is to be preferred for assessment of fibrosis and inflammation. So this is about the part 1 of liver biopsy. I hope you have understood in details, everything that I have discussed. So I have already discussed in details about the basic introduction, types of biopsies, indications, contraindications, prerequisites, procedures, complications, adequacy, handling, processing, and the choice of stains, including immunohistochemistry. Okay. So in the next lecture, we will discuss about the more interesting basic interpretation of liver biopsy. Thank you very much for watching this particular video.